So this morning's session we've got Yvonne Wren, who is an ambassador for a patient charity. Yvonne's going to tell you a little bit about her story about living with an autoimmune disorder. So I'll pass over to you, Yvonne.
Thank you, Nick. Good morning, everyone. Hi. I've been asked to do this talk about living with autoimmune disease and how it affects my life. The first thing I'd like to do is to apologise for use of notes. It will become apparent later why I'm having to use them, and I really don't want to miss any information out. So I am a 72-year-old retired physiotherapist who worked for the NHS for 35 years. I have 2 grown-up children and a granddaughter of 6 years old who I adore but totally wears me out. I also have antiphospholipid syndrome. So I'm going to talk to you today about APS, what it is, the causes, the incidents, the symptoms, and my story of living with APS and how it affects my life. So antiphospholipid syndrome, or APS as we call it, it is an autoimmune disease which affects the blood and its ability to clot. An overactive immune system produces antiphospholipid antibodies which cause the blood to clot too quickly, both in veins and arteries. The clotting can affect any vein, artery or organ of the body, and the consequences can have cause potentially fatal conditions such as heart attacks, strokes or DVTs. In pregnancy, the antibodies are the most significant cause of recurrent miscarriage, preeclampsia, small babies, early deliveries and stillbirth. So as the blood flows through the entire body, antiphospholipid syndrome can present a wide variety of symptoms, not all of them, fortunately, as serious as stroke or heart attacks. So causes. Well, as yet, we simply don't know why people develop APS, why some patients go on to have blood clots while others don't, why some women, but not all, have pregnancy problems, and why some patients are affected by symptoms more than others. Vital research is needed before we can answer all these questions. However, we do know that the root cause is overactivity of the immune system. We're not sure why the immune system becomes overactive and is unable to distinguish between foreign invaders and its own body constituents, but there is increasing clinical evidence that there is probably a genetic tendency which is triggered in people who have the condition. Again, at this stage, it's unclear what triggers the disease, but a person's genetic makeup and exposure to certain trigger factors may provide the right environment which APS can develop. For example, viral infections, viral infections such as glandular fever or shingles, stress, and certain drugs. Other well-known precipitants of thrombosis can act as triggers for the syndrome, such as immobility, dehydration, surgery, the oral contraceptive pill, and pregnancy. So how common is it? It's difficult to engage, as the condition is often under-recognised and under-diagnosed. And as yet, there have been no large-scale epidemiological studies carried out to provide prevalence data. However, evidence from a robust study carried out in 2019, the Epidemiology of APS, a population-based study, indicates that the prevalence of APS in the population is 1 in every 2,000, which means it can be classified as a rare autoimmune disease. This study is significant as APS was previously thought to be more common, even guesstimated to exceed the numbers of people who had Parkinson's disease, but this now appears to be untrue. So as widespread research has yet to be carried out, we can only base our statistics on smaller studies. But in general, a general approximate guide, which can be applied to APS, is the 1 in 6 rule. So 1 in 6 young, that's classified as under 50, strokes, will be diagnosed with APS as the cause. 1 in 6 young DVTs, the same. 1 in 6 under 50s who have heart attacks, the cause will have been APS. And 1 in 6 recurrent miscarriages. Women are 5 times more likely to have a stillbirth if they have APS. In pregnancy, APS is the most common potentially treatable cause of recurrent miscarriage. Women are more likely, I said that bit already. The thing is that before some research was done into pregnancy and APS, about 80% of women lost their babies before full term. And when they refined and researched the treatments for pregnant women with APS, they've now managed to totally change that. So 80% now, with the right treatment, are actually going to full term, which is a huge success. People from all ages, including children, can have APS, but it does tend to mainly affect the age range 20 to 50, and women more so than men. For every 2 men with APS, there are 7 women affected. In recent years, there's been a movement towards international collaboration, and researchers have now joined together to create APS Action, the alliance of clinical trials and international networking. The trials and collaboration will hopefully yield some concrete statistics and also improve treatment options for patients in the future. So what are the symptoms? I'll just run through these. They can be low-grade symptoms, but there also can be potentially fatal events as a result of the blood clots. So the low-grade symptoms of APS can lead to misdiagnosis. Some people have been diagnosed with MS and they actually have APS. The symptoms are common with quite a lot of conditions, especially autoimmune disease. So headache and migraine are very common in APS. Often people experience them for years and years. And it just gets dismissed without being investigated as a migraine. Memory problems, memory loss affects many people with APS who often have difficulty thinking clearly and describe the sensation as a brain fog. Dizziness and balance difficulties are another problem. Blotchy skin called livido reticularis. That's, it gives the appearance of a skin like a giraffe pattern. Arthralgia or joint pain, it's relatively common in APS patients. Arthralgia is less severe than full-blown arthritis and tends not to be inflammatory in nature, but still restricts mobility. Many people, including myself, are treated with hydroxychloroquine, which is an anti-malarial drug previously used very successfully with lupus patients, and it relieves arthralgia and fatigue. Fatigue is a big issue for APS patients. Most patients with APS find they suffer with fatigue at some point. Fortunately, it doesn't tend to be constant. You have good days and bad days. It's characterized by a lack of energy and motivation. Unlike drowsiness, which is your body's signal that you need sleep, fatigue's often accompanied by a general feeling of heaviness and muscle aches and pains. It can affect you mentally as well as physically and sometimes feels completely overwhelming. So while almost everybody experiences tiredness throughout the day, fatigue caused by APS is more extreme. It can cause complete exhaustion, doesn't go away with sleep or rest, and does limit your activities of daily living. The common acute events are thrombosis or DVTs, usually occur in the deep leg veins. People of all ages can be affected, with 1 person in every 1,000 in the UK developing a DVT each year. It's estimated that 10% of these cases will test positive for APS. Incidentally, there's, just as a warning really, there's an increasing number of people who are presenting with what's known as e-thrombosis, which is from sitting at computers or gaming tables for hours at a time. Just get up and walk around when you're studying. Another event that can happen is a stroke or a mini stroke, also known as a transient ischemic attack or TIA. These are the most serious neurological symptom associated with APS. Strokes develop when a blood clot blocks the supply of blood to the brain. Unfortunately, it's the first sign of the condition in 13% of people who have APS. It's usually associated with the older population, but with APS it occurs among young adults several decades earlier than you would expect it to. So TIAs and mini strokes are when the blood clot causes a temporary blockage to the brain. The symptoms are similar to a stroke, but can last for only a few minutes up to the whole day. And then they disappear, which is why they're called transient. And TIAs are the first sign of APS in 7% of patients. Then you've got pulmonary emboli occur and recurrent miscarriages, the majority of which miscarriages in APS occur at the earlier stages of pregnancy in the first 13 weeks. And late pregnancy loss is very strongly associated with APS, with a number of losses occurring between 3 and 6 months. So although these are the most common symptoms of the condition, as APS is a blood disorder and the blood flows throughout the entire body, nearly any organ can be affected. Consequently, the brain, eyes, ears, lungs, heart, kidneys, liver, bowel, skin, nails, bones, joints can all potentially be affected to varying degrees. So, my journey living with APS. So APS is diagnosed from a combination of positive blood tests and symptoms, and I received confirmation of my diagnosis of APS when I was still working as the physiotherapy clinical therapy lead for intermediate care in Southwark in South London. I was diagnosed at St Thomas's Hospital on the 21st of April 2005. It's embedded here, that date. I was 52 years old, so it was 20 years ago. I thankfully lasted well, despite a few ups and downs. I had never been someone who suffered from headaches previously, but I had had a couple of migraine-type attacks during both my pregnancies in the 1980s, and subsequently once or twice a year after that. I'd begun to experience marked memory problems that were worrying, particularly at work, and I was worried I might even have early onset dementia because it was quite marked symptoms. Meetings were particularly difficult. I can remember a senior management meeting I went to, and I started to say, right, there's 3 things we need to sort out, and said the first, and I thought, God, what was the third? Said the second, still couldn't remember. I knew I wouldn't be able to remember it, just completely gone. So I just, at the end, said, I'm sorry, I'll come back to you if I remember it, but I didn't. So when I mentioned this to my consultant, she said, Yvonne, your hard drive is full, don't worry about it. But I did worry about it. It was a problem for me. So in 2003, 18 months before I was diagnosed, at age 50, I suffered one of these attacks at work, resulting in a severe headache, photophobia, flashing lights, fragmented vision, impaired memory, confusion, inability to process actions, all at one time. I was trying to make a phone call, I was pressing the buttons, couldn't remember who I was meant to be ringing, what numbers I was ringing. Honestly, it was a horrible experience. And then one of my colleagues came to the door to ask me a question, and I looked at her and I knew her, but I couldn't remember her name, or what she did there. I just recognised her, and I said, I'm really sorry, I don't know who you are. And she went and got the manager, and I thought I was having a stroke at the time, and they carted me off to A&E, local A&E. But by the time I was seen, the symptoms had got a lot less, and I was sent home. And the whole episode was put down to stress, as they do, as I was dealing with a very difficult home situation at the time, and dealing with menopause. So a week later, I was told I had swelling at the back of my eyes following a routine eye appointment, and sent back to A&E to have it investigated. When I got there, no reason was given, and they couldn't find anything wrong, and they said the optician had overreacted, go home, it's fine. So I left A&E pretty sure I got some sort of space-occupying lesion in my brain. At this point, one of my oldest, dearest friends, who was a medical consultant, rang me and insisted on arranging for me to have an MRI scan because I'd had several of these type of episodes. Well, I was very reluctant for this to take place, mostly because of the cost, of course. But thank goodness I did agree, as it actually identified some lesions in both cerebral hemispheres of my brain, indicating I'd had TIAs, and I was referred to a neurologist. Again, very lucky, extremely lucky that he knew about antiphospholipid syndrome, which was considered a newly recognised condition because it had only been described as a syndrome in 1983. And this neurologist considered it as a possible diagnosis and referred me to a haematologist. I then had the 3 blood tests over a period of several months. They had to be repeated, and they were used to diagnose with the history of blood clots as well. So I had the 3 ones that are specific for APS are the anticardiolipin antibodies, lupus anticoagulant, and later on came the anti-beta-2 glycoprotein 1. Which always reminds me of a football result for some reason. So. Finally, 18 months after the major migraine type episode, I had experienced the one I experienced at work, and after numerous blood tests, I was diagnosed with APS and started on large doses of warfarin for life. Incidentally, the average time it takes for someone to be diagnosed with APS is 3 years, and within that time people may have recurrent, and they do have recurrent thrombotic episodes. I was lucky, very lucky. In my case, it wasn't a matter of what you know, it was who you know. So the management of the anticoagulation that I was taking was undertaken by my local hospital anticoagulation clinic. The staff have always been brilliant and really supportive. But of course it meant weekly visits to the clinic to monitor the INR. My therapeutic range had been set, what is regarded nowadays as too high, but at that time, 20 years ago, it was 4 to 5, and the visits were very disruptive to my work. As I said, they were so time-consuming. The size of the anti-coag clinics is huge. You sit for ages and ages. I mentioned the INR. Are you all familiar with INRs? I don't need to explain the International Normalized Ratio. It's a measurement of, some people are saying no, some are saying yes. It's a measurement of how quickly the blood clots. So 1 is normal speed for measuring. So 4 to 5 means it takes a long time to clot. And that's why you take your warfarin, because with a blood clotting disorder, you want it thin as possible, but without risk of bleeding. And that's, you'll see, is a real balance. So at this stage of having been diagnosed and started treatment, I don't really think I had taken in the full meaning of the diagnosis or its implications. It had been explained to me, and I'd done the inevitable internet searches, which in those days had very little information, I have to say. But I hadn't really fully realised the impact it would have on my life. I was, at the time, just relieved I hadn't been diagnosed with dementia. The symptoms vary depending on my INR, which responds differently to many things, including foods with a high vitamin K content, alcohol, sadly, some medications, exercise and long distance travel. I can tell if the INR's dropped. I begin to feel very vague, very forgetful, sometimes confused, amuses my family and friends. I have headaches, blurred vision, facial numbness and increased tinnitus, and I feel fatigued beyond just tired. I've told them to stop laughing at me now when I forget things, because it's not funny anymore. Initially, I worried continuously about bleeding or clotting, as the INR was hard to stabilise, even with weekly checks at the hospital. And after a year of taking warfarin, I managed to buy my own CoaguCheck XS monitoring machine. At the time cost £400, but I'd had a big win at bingo, so I bought it. And because of my medical background, the haematology nurses encouraged me to self-monitor and self-medicate, so I was completely self-managing. But I had a contract with the hospital that ensured I would seek advice if the INR went outside certain parameters. They also taught me to self-inject with Clexane, the low molecular weight heparin, and supplied me with preloaded syringes if my INR went too low. So at this stage, early on, the most important people to me, apart from the health professionals, were my family and friends, especially my 2 children, who were and still are my best friends and supporters. And there they are. So, and their spouses now. I had a few other medical problems, as well as picking myself up from previous domestic problems, going through the menopause, dealing with my mother's diagnosis of cancer and subsequent death 3 months later, all only a year after my own diagnosis of APS and all the anxieties that was calling me. I had health anxieties and panic attacks, which were things I'd never experienced before. If I started to have a headache, I was fearful I might develop a serious vascular event. This made my heart rate and blood pressure go up, which made me feel worse. It was really frightening. I didn't know what to expect. My children and best friends learnt as much as possible about APS and were always there for me to talk to, day or night if necessary. And I'll just say as an aside from this that 2 of my work colleagues, both nurses, were working with people whose daughters were having recurrent miscarriages. And when they found out more about APS from me, because I was telling everybody everything about it, they said to them, why don't you recommend that your daughters get the blood tests and see? And both of them were found to have APS, and they've both had full-term deliveries of babies. So that was just spreading the word and letting people know. So during the next couple of years, I had some hospital admissions, one of which was by ambulance with a suspected cerebral hemorrhage. Neither of the paramedics had ever heard of APS or realised the importance of remaining anticoagulated to avoid another TIA or stroke. It really scared me that I had to try and explain the condition when I wasn't really feeling very well. And again, on arrival at A&E and on the ward, I found that so few people had heard of the condition, even though it had been described, well, it was 22 years before in 1983. Also, I had constant battles with the doctors who wanted to stop warfarin or reduce my INR range, both of which that could have easily led to a thrombotic event for me, as my risk of clotting was very high. Even my GP, who'd been wonderfully supportive, panicked when I said my INR was 4.3. I said that was a level that had been set by my haematology consultant, and he literally grabbed the edge of the table and said, "Role reverse, patient reassuring doctor." So I didn't know what to do with all these people who didn't know anything about it, who should have known. It's really important to be able to communicate about the condition to doctors and nurses without sounding like an internet know-all. And it's hugely reassuring when you find a medical member of staff who knows about APS. When I travel to non-English speaking countries, which I am fortunate to be able to do on occasions, I plan, there's an example, beautiful. I plan ahead by going to the website of that country, looking up APS and printing off the information about the condition in their language. That way, if I'm admitted to hospital for any reason, I have the information available to understand. Being able to self-manage the warfarin and INR liberated me completely. It was unbelievable. I felt empowered and more in control of the condition. I'd been asked to go on holiday to Hawaii in 2009 with a good friend. It was a lifetime dream. But I was worried about flying so far for so long, working out my warfarin doses, which had to be taken absolutely regularly, whilst crossing 10 time zones in 20 hours. It's a very long way. And also dealing with the inevitable increase in alcohol consumption and other changes. So I set about planning. I made sure APS was properly stated on my travel insurance. It's very important. They put some other blood condition down originally, and I sent it back to them. They said, "Oh, I don't know, we've got your one on our list." And now they do, and there's lots who have pre-existing medical conditions included. It costs you, but they're included. I bought a digital watch. Now, I'm sure everybody in this room say, "Why didn't you use your phone?" Well, in those days, they weren't as sophisticated. I set the alarm to the time I usually take my warfarin. I kept it on UK time. I had my other watch set locally, but that one stayed, and it beeped every time I was meant to take my warfarin, whether I was on the beach or sightseeing or whatever I was doing. The long flight, which ended up being 16 and a half hours, affected my INR, and it dropped dramatically. I began to feel unwell after a day, headache, blurred vision, and what I call my mushy pea brain fog. So I checked my INR, found it was very low, injected myself with heparin, and increased my warfarin dose over the period of days until the INR was back in range. I visited a local doctor in his Hawaiian shirt who prescribed extra Clexane syringes so I didn't run out of heparin while I was there, use them as top-ups if I needed. So it meant I avoided a costly and time-consuming visit to a hospital in Hawaii, and also it prevented a thrombotic event. He said to me, "Come back the next day for your letter." And I said, "Oh, okay, fine." He said, "You know, your insurance letter." So I said, "Okay, that's fine." The actual visit cost, for the visit and I think it was 5 or 6 syringes, $600. So I'm glad I was insured. So as far as the alcohol's concerned, it's important to know your limitations when you take warfarin and have a bit of self-control, which is why I keep meaning to change this picture. There are stories about being on warfarin and not being able to eat Brussels sprouts or other vitamin K-filled green vegetables or drink alcohol, but you can eat anything and drink as long as you eat the same amounts regularly and don't binge on food or alcohol. So I'm very fortunate to have undertaken many trips since that original trip, including an East Coast trip of America, from New York to North Carolina, a 1,000-mile, 3-day road trip into the Utah and Arizona mountains and monuments, miles from anywhere or any hospital. We ended up in Nevada. I had a wonderful trip to Yellowstone Park, again, miles from anywhere. And last November, we did an amazing trip to South Africa and Namibia, which was extraordinary. And again, you know, Namibia, we were miles from anywhere. So I am extremely, extremely lucky, and I appreciate it. And these were really big adventures that I was able to enjoy to the full, knowing how to manage my own condition, medication and treatment, even miles from civilization. However, sometimes things go wrong. So in June 2016, I had to have my gallbladder removed as it was harbouring a huge gallstone and causing me a lot of pain. 2 weeks after it had been removed, I experienced increasing severe abdominal pain, and my GP came to see me and called for an ambulance to come within 2 hours. Unfortunately, there were no ambulances available, so even that long ago it's a problem. So just before the 2 hours were up, they sent a minicab. I could hardly stand up by the time it had arrived. And he dropped me off at the urgent care entrance of A&E, as it obviously wasn't allowed to go into the ambulance area. Consequently, I wasn't seen for hours, especially as it was a Friday evening in Lewisham. Eventually, after about 5 hours, and with a lot of pressure from my family who descended on A&E, I was seen by a doctor. I thought I was going to die, and later I was told by the doctors that they did too. It's the most frightening experience. Felt totally, totally out of control. What had happened was I had suffered a massive internal hemorrhage, and over the next 2 weeks as an inpatient, I had 5 blood transfusions, a constant heparin infusion titrated 4 hourly, so I had 4 hourly blood tests, day and night, 3 lots of combined antibiotics, IV, and developed bilateral hypostatic pneumonia and pleural effusions, necessitating continuous oxygen. The medical staff on the ward were wonderful, and they were supported by the haematology APS specialist consultant, Professor Beverly Hunt, at St Thomas's Hospital, as I was in a precarious position of being able to clot and or bleed at the same time, and it needed to be very delicately managed. I had 4 hourly blood tests, 24 hours a day. It was totally overwhelming. The hemorrhage was caused by bleeding from the liver bed combined with the use of warfarin and heparin at the same time, which I was using for post-operation bridging. I don't know if you understand what happens with that. When you have surgery and you're on warfarin, you have to stop it a couple of weeks before so the INR drops, but to keep anticoagulated, you inject yourself daily with heparin. And when you've had your surgery, you can restart the warfarin, but until the INR reaches the right level, you have to keep injecting with heparin. So I was doing both at the same time. The bleed wasn't because I was self-managing and not doing it properly. Apparently it would have happened anyway. I think the liver bed just ruptured. I'd never been in so much pain, even in labour, or as terrified as I was that first night in A&E. It took me weeks to recover, physically and mentally. Months, really, I suppose. And my GP said suffering from post-traumatic stress syndrome. I was emotionally labour for months afterwards, very easily tearful, very weary, no energy, totally deconditioned. However, I did have the biggest incentive to recover as my daughter got married 3 weeks to the day after I was discharged from hospital, having been threatened to be wheeled there in a wheelchair if I was still in hospital. And, I made a supreme effort on the day to be involved and enjoy the wedding, which somehow I managed to do. So my daughter's doing the jumping, I'm just pretending. So, so yes, the thing was, you know, I was sadly in no fit state for the hen nights, but the wedding was great. So 4 years after I received a pre-diabetic diagnosis, following a routine blood test, with an appalling family history of diabetes and being clinically obese at the time, bigger than now, I resolved to change my diet and exercise more. I really needed to avoid any other medical problems. So for a start, I stopped eating a family bag of Haribos every night. Pretty addictive, aren't they? I lost, a stone and a half, 9.5 kilograms in 6 months. Then I joined Slimming World and lost another 2.5 stone, that's 16 kilograms. Done the conversion for you young uns. So 4 stone in total, which is 25 kilograms, according to Google. During that time, I planned to walk the Thames Path National Trail. It's 184 miles in total from Gloucestershire to the Thames Barrier at Woolwich as a challenge on my own before my 70th birthday in March 2023. Even now it sounds nuts to me. Everybody says you must be crazy, but it was the most amazing experience. I completed it in December 2022. It took 8 months over 25 stages. It was absolutely incredible. But I couldn't have achieved it without the weight loss. So there's getting ready to head out. It was extraordinary. Walk by rivers, it's really therapeutic, it's wonderful. Oh, you pop up. So, however, the change in diet and the loss of weight affected my INR. And it's been quite difficult to keep it in therapeutic range. I had lots more leafy green vegetables that upset the warfarin. But, you know, I continue to manage it successfully at home. So even trying to be healthy causes problems when you've got this. Recently, I had a haematology appointment where I was instructed to lower my INR to a range of 2 to 3 now, because I'm getting old. And, well, although I'm 72, I feel like I'm 22 quite a lot of the time. But apparently the blood vessels do become frailer as you get older, and there is an increased risk of bleeding. So I also have to increase the statins that I take, not because I've ever had high cholesterol, but they're part of the treatment that we have for APS, and help to reduce risk of clotting. So it's all very complicated in the end. So in conclusion, I was shocked when I first received my APS diagnosis and wasn't sure how I was going to deal with it. However, I love life. I'm always determined to get the most out of it, especially with, here she comes, my wonderful granddaughter. Self-management has completely liberated me and enabled me to continue to take part in many activities I enjoy, including playing the steel pan, lawn bowls, and long walks. I'm also grateful to my children and other family members and friends. Also to all the medical and nursing staff who've treated me and supported me. Also to the charity APS Support UK, which is an absolute mine of information. And I would recommend you look at their website for more details about APS and access to recent research papers. Research has actually increased a lot around APS since the pandemic on the discovery of transient antiphospholipid antibodies in patients with COVID. All of a sudden, the research was ramped up enormously. Patients were having not pulmonary emboli, but pulmonary thrombosis. And the antibodies, the antiphospholipid antibodies, were discovered. There are fact sheets. There you go. Take the website information. There are fact sheets on masses of things. Diet, food, things that affect warfarin, on self-management, travel, how to visit your doctor and tell him what your symptoms are, visits to the dentist, if they're pulling teeth, you know, what should your INR be. There's a specialist directory on there which has been really useful. I worked for 6 years as an admin assistant for the charity and was asked to compile the directory of specialist consultants around the country. What was happening was the hub of APS treatment and diagnosis was London. And people were travelling from Glasgow and Cornwall to come up to London, bearing in mind these are people who probably suffer a lot of fatigue, would have to pay the expense of travelling to London, would have to stay overnight. They probably wouldn't have had the energy to stay in London and pay for their bills. They'd have to stay in London. They wouldn't have the energy to go back in one day after a consultation. So the directory began by patients coming to the charity and saying, oh, I saw this really good doctor in Birmingham or Manchester who seemed to know all about this and has done all the tests he's meant to do. And so the charity got more and more of this information from all around the UK, and the manager contacts the consultant and said, would you be prepared to be put on our directory of specialists for APS? And people can look up on the website and go to those rather than coming all the way down to London. So that's been a really useful item on the website. There are fundraising ideas, there are posters and pamphlets, there are patient stories as well. I'm an ambassador for the charity and fully recommend you have a look. It punches way above its weight. There's one full-time manager, Kate, who's incredible, and there's 2 part-time admin workers now. And they do a huge amount when raising money to be able to pay for grants for people to do more research. And so it's really worth looking at. And that concludes my talk. So thank you. You're welcome.
I think Yvonne is happy to take questions, if any of you have any.
When you had your gallbladder operation, were you advised to consult your haematologist?
I did, and it should have all gone fine. It was a routine cholecystectomy, absolutely fine. But for some reason, I don't know if they didn't suture properly when they finished. It was something that happened after, I suppose, because my risk of bleeding was more. I mean, it was a massive hematoma. It took about 8 months to reabsorb. It was terrible. It should have been just a normal routine operation without any complication. Do the bridging, pick up with the warfarin afterwards, get your INR back to normal, off you go, pain-free. But for some reason, it's not usual to happen, I don't think. Normally they're just very straightforward. So my haematologist knew about it because I got advice beforehand. But yeah, it's just one of those things, sadly.
Your diagnosis took 3 years. Has the time taken improved?
It depends who you see originally, how much knowledge they have, I think. It has got better, it has. More people are being diagnosed, but it is dependent on the knowledge of the clinician you see, really. It's very under-taught in medical schools. We've been trying to get in there and trying to get more information in and see if we can increase the curriculum input. We've had quite a lot of success because it wasn't being routinely checked on young people with heart attacks and strokes. We got in with the, I can't remember, the clinical guidance groups, and it's now registered that if somebody under 50 has had a stroke or a heart attack, that they get tested for APS routinely rather than way down the line when they still may be having more clotting events. So, yeah.
After your diagnosis, you said you'd get scared if you had a migraine. How do you cope with that now?
I tend not to get them now because I'm not getting my blood's flowing fine at the moment. I do get, if my INR goes low, I get increased tinnitus and I do get some symptoms. I sometimes get some facial numbness. I do get muddle-headed a lot, but age probably I've probably got, small vessel disease in there anyway. But I do worry if I go to bed at night with a headache, not frequently, but if I do, when I wake up in the morning, I do think, oh, still here. So yeah, it is a worry. It is a life-threatening event. I mean, anything could happen any time. That titration that was happening with the heparin infusion was crazy when you think about it. I was literally at risk of clotting and bleeding at the same time. It was just mad. I had this massive solid hemorrhage going down to my pelvis and from my liver, and I was being given this, blood thinning stuff. It was just crazy, really. And it had to be minutely managed. Before I actually lost consciousness in A&E, and my son had arrived, and I said to him, for goodness sake, give them Professor Hunt's phone number. She must be involved. And they did. And they rang her, and I was hugely reassured by the nurses coming up and titrating the machine, the infusion, and saying, well, Professor Hunt said it needs to go to such and such. And I thought, oh, thank goodness. And when I saw her after some months after, I went back to see her, and I said thank you, obviously, for her input. And she said, Yvonne, don't ever do that to me again. I'm not going to manage you remotely anymore. You get yourself here. And I said, oh, I don't think I could have on that day. But yeah, it is scary. I try not to think about it. I just get on with my life. As you can tell, I'm very active. I've got a tricycle I ride now, and great big thing. I can hardly lift it. It gets wedged in the front door. It's so big. But yeah, go for it. You can't sit there worrying all the time. Although there are occasions when you're not well and you think, oh, where's this going to go?
Is rivaroxaban a treatment option?
Not for all APS people. It's a very interesting topic. There has been a trial. I think I'm not sure if it's actually being used, but for DVTs, for venous thrombosis, but not for the arterial brain ones. The trial had to be stopped at some stage because it was not successful. And there were some events that made them think, oh, this is not working. We can tell now this is not good. So I can't have it. I'm not sure I would change, although warfarin's not a particularly nice drug. It's kept me going for 20 years. And I'd be reluctant to change. I like to be able to monitor it and see where it is on my INR, know exactly, I can tell the difference, I can feel where it is. And I feel reassured by that. You don't have any monitoring with all the direct oral anticoagulants. So you don't have any, Pixaban, rivaroxaban, any of those. You don't have the monitoring. So, yeah, I'm not sure. I think I'm too used to it. I think quite a few people on warfarin say that because, we're still going strong on it. We're okay. Although it is a bit of a hard hitter sometimes. Yeah.
Okay. Well, thank you very much again, Yvonne, for
You're
sharing your
welcome.
experience with us.
You're welcome.